Hello dear students, welcome back to the dental class. Today I'll be teaching you about inferior alveolar nerve block or inferior dental block or mandibular block. The purpose of inferior alveolar nerve block is when we need to perform procedures in mandibular teeth in one quadrant or when lingual soft tissue anesthesia is necessary. The steps of performing local anesthesia injection in oral cavity generally and inferior alveolar nerve block specifically are: first and the foremost is using sterile needle of about 25 gauge. Then we will check the flow of the needle, warm the anesthesia cartridge if needed. Then patient positioning should be done. Physiological supine position should be used for all regional blocks to avoid vasovagal syncope except in contraindicated conditions or the patient or the dentist's own preferences. Then the tissue should be dried to help in retraction. Then apply topical antiseptic, but it is optional. After that, apply topical anesthetics for about 2 minutes and at the same time communicate with the patient. Establish firm hand rest and keep the tissue taut to avoid mishandling and allowing the needle to easily and smoothly cut through the tissue. By keeping the syringe out of the patient line of sight, insert the needle into the mucosa while communicating with the patient. The point of needle insertion is determined by two factors. Number 1. Height of the injection. It is along the imaginary line parallel to the mandibular occlusal plane and 6 to 10 mm above it. Number 2. Antero-posterior position of the injection. It is the vertical line from coronoid notch of about 3/4 distance from anterior border of ramus to pterygomandibular raphe. The intersection of these two lines determine the needle penetration site. Now, inject few drops of local anesthesia in the start, but if you are using buffered local anesthetic solution, then that would not be needed. Slowly advance the needle and after penetration of about 20 to 25 mm, the needle location will be slightly superior to the mandibular foramen. Deposit few drops of local anesthetic solution just before touching the periosteum, as periosteum is very painful. Always aspirate twice by turning the needle at 45-degree angle before depositing the bulk of local anesthetic solution. Then deposit slowly at a speed of 60 seconds for 1.8 ml of cartridge and keep the patient engaged. Then slowly withdraw the needle. Observe the patient and keep record of this injection in the patient chart. After that, wait for 3 to 5 minutes before checking the anesthesia effectiveness. The patient should not feel any pain and have tingling sensation in the lower lip and tongue on one side. Now a little bit about the anatomy of the site. While inserting the needle, it passes through mucosa, pterygomandibular raphe. Then inside the pterygomandibular space, which contains lingual nerve, inferior alveolar nerve, and inferior alveolar vein and artery. The nerves that are anesthetized by inferior alveolar nerve block are inferior alveolar nerve, lingual nerve, mental nerve, and incisive nerve. And they anesthetize the following tissues: mandibular teeth up to the midline, body of the mandible, buccal mucoperiosteum and mucous membrane anterior to the mental foramen, anterior 2/3 of the tongue and floor of the mouth, lingual soft tissues and periosteum. Now that we have reviewed the correct technique, let's learn about the reasons of failure of inferior alveolar nerve block. Number 1. Needle tip is located too anterior. In that case, bone is felt too soon. Or the needle tip is located too low. The needle tip may be located too far posterior. In that case, the bone will not be touched. In all these three scenarios, reposition the needle without withdrawing it. The fourth reason of failure is excessive nerve supply to the mandibular teeth. For example, nerve to the mylohyoid. In that case, infiltrate on the lingual side of the molars. Let's learn about few mishaps that occur with inferior alveolar nerve block. Number 1 is hematoma. Application of pressure is needed to treat the hematoma. Number 2 is trismus. Trismus is limitation in mouth opening. It is due to the injection into the middle pterygoid muscle. And for trismus, the patient should be advised warm saline, heat therapy, analgesics, muscle relaxant, and physiotherapy. Number 3 is transient facial nerve paralysis. That is due to the injection too far back and without feeling the bone. In that case, reassure the patient, remove the contact lenses if any, and apply eye patch to preserve corneal lubrication. The last piece of information is about bilateral inferior alveolar nerve block. It is very rarely indicated, like in bilateral mandibular surgical procedures. The problem in bilateral inferior alveolar nerve block is the patient feels unable to swallow. Self-inflicted injury to the tongue and lips can occur. Speaking ability will be compromised for the duration of local anesthetic effect. Alternatives to the bilateral inferior alveolar nerve block can be bilateral incisive nerve block or one-side inferior alveolar nerve block and one-side incisive nerve block. With this, today's class is over, but one quiz question in the end. The question is, why should we aspirate twice while injecting? Write down your answer in the comment section below. And don't forget to like and subscribe to the dental class. Take care, bye bye.